So, friends, I'll be giving a brief overview over this topic that was given to me for Delhi Critical Care Symposium that happened on 10th November. So, is transpulmonary thermodilution obsolete in the context of point of care ultrasound? So, this was the topic. So, I wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So I'm sure most ICUs now currently are downpedaling the usage of transpulmonary thermodilution and possibly doing more of ultrasound. So after having reviewed the whole literature, so upfront I can say the answer is possibly yes. So TPTD, transpulmonary thermodilution, possibly would get obsolete would be my answer. So when we talk about it, we need to understand the way we would approach this is what are the different devices that are available that uses the science of transpulmonary thermodilution or thermodilution, and what are the distinct advantages of echocardiogram. So when you talk about cardiac output monitoring devices, the earliest one is the pulmonary artery thermodilution. So we have PA catheter for it. Then we had this transpulmonary thermodilution, which is the PICO catheter. So if you look at this in a figurative sense, so it's a very simple sort of a concept that where you put a catheter into the right atrium, so into the SVC and right atrium, and you give a cold injectate. So this cold injectate goes into the pulmonary circulation and it reaches the systemic circulation. So we look at the change in temperature from the injectate that is put into the SVC or right atrium after having passed through the pulmonary circulation and reaches the systemic circulation in the femoral artery. So we have two catheters, one in the CVC, one in the femoral catheter or in the axillary catheter. So we look at the change in temperature for the blood to reach from the venous circulation to the arterial circulation. Based on the temperature change, cardiac output is calculated based on different algorithms and equations. So that is the essentially pretty much the science of whole thermodilution, sort of a science that we follow. And the third cardiac output that has evolved is arterial pressure wave. So we use flow track or Vigilio, where we look at the area under the stroke volume and we calculate the cardiac output based on certain formulas, which I'll very briefly talk about. So after that, we have esophageal Doppler. So I think in UK, this is more commonly used. And as the name suggests, so you have a probe sitting in the esophagus, which is close to the aorta, where you check the stroke volume based on the traces that come. And the tool that we have is CardioQ. And then we have bioimpedance. So some of the trade names that are there for the bioimpedance, where we look at the change in the voltage in sort of two different dimensions in the body, and then the cardiac output is derived. So there are TEPCO, Hotman, and Lifeguard. Then you have this bioreactance, so non-invasive cardiac output monitoring with bioreactance. So these are different tools and modules that we have to calculate cardiac output. Since the topic is more of thermodilution, we won't talk too much about esophageal Doppler or bioimpedance because thermodilution is limited to more of PA catheter and PICO, transpulmonary thermodilution, and to some extent, the pulse contour analysis. And of course, then we have the echo. So these are the different tools that are currently available where you can calculate cardiac output based on sort of the science that we just spoke about. So as I said, the principle of cardiac output monitoring, which again I showed you in the previous figure, is you put some sort of an injector. It can be indicator injector. Like if you talk about LITCO, we give lithium indicator. So in transpulmonary thermodilution, we give cold injected. PA catheter, we give a cold injected. So we put an injected into the venous circulation and look at the change in temperature at the arterial, and then we derive the cardiac output based on Stewart-Hamilton equation. So this is simply Stewart-Hamilton is the volume. So V stands for the volume of the injectate. TB is the temperature of the blood. TI is the temperature of the injectate. K1 and K2 is the constant. And this is change. TBT is the change in temperature as a function of time. So how much time it takes and for the temperature change that has happened in that time. So this equation is used to derive the cardiac output in the PA catheter. So this is simplistically the science. So, but when we talk about PA catheter, so obviously we need to understand there are a lot of limitations and caveats. So when you put a PA catheter, so the ideal position is this is zone 1, this is zone 2, zone 3. So PA catheter has to be sitting at zone 3. So when we say, so which means these are the caveats, because if it is in other zones, then the readings become erroneous. So when we say zone 3, as you see, the pulmonary artery pressure should be more than alveolar pressure, and the alveolar pressure should be less than pulmonary venous pressure. And as you see, the PA catheter is sitting here, zone 3. And there are criteria to determine as to how the PA catheter is in the zone 3, because the pulmonary artery occlusive pressure should not be more than pulmonary artery diastolic pressure, or pulmonary artery occlusive pressure should be less than pulmonary artery diastolic pressure. And PEEP should not have a great influence in altering the pulmonary artery wedge pressure to more than 50%. It means even whatever PEEP alteration, your change in pulmonary artery occlusive pressure should be less than 50%. And change in arterial pressure also should not influence pulmonary artery occlusive pressure to more than 50%. So these are some of the criteria that are there to depend completely on this as a tool to monitor cardiac output. And there should not be arterialization of the blood at a site in the pulmonary artery where there is a wedging that has happened or where this balloon is inflated. So there should not be mixing of the blood. So these are some of the caveats which influences the readings from the PA catheter. And these are some things, these are the caveats that are there when you're using PA catheter. And there are other limitations is because PA catheter may calculate cardiac output, but it does not tell you whether the cardiac output is a representation of the right ventricle or the left ventricle. So it does not delineate or differentiate between the right and left heart. And if there is a regurgitant lesions like MR, mitral regurgitation, so the readings become erroneous. And the pulse pressure variation also is quite variable with the stroke volume. And suppose if patient is hypothermic or has a high fever, because it looks at the change in temperature as a function of time. So the change in the body temperature also has an influence on the cardiac output measurement that happens. So these are some of the limitations of PA catheter. Why we are talking about limitations? Because these are the limitations that possibly we are talking about when we are interpreting cardiac output when you use these devices. And more so, when you're using PA catheter, there are a lot of complications. There can be PA rupture, and mortality in case of PA rupture or damage is mortality up to 50 to 70%. And there can be pulmonary infarction, and there can be endocarditis. And obviously, you're putting a PA catheter, there can be dysrhythmias or conduction abnormalities, catheter knotting or overwedging, and you cannot keep this catheter for more than 70 hours. And for all the intensive care community, we know in our science, I think PA catheters are pretty much becoming obsolete. More it is being used in cardiac setting or cardiologist sort of a setting they tend to use. But in our ICU, pretty much studies have shown that this does not have a great benefit, and because of the complications, and you cannot keep them for a long time. So now we'll talk about transpulmonary thermodilution, like the PICO catheter. So this is, we used to use a lot in Australia, but there are problems with this also because the injectate volume, if it is incorrect, and the small changes in the temperature tends to overestimate the cardiac output. And when there is more difference between the injected temperature and the body temperature, that also overestimates the cardiac output. And the indicator that you give can be sequestrated when there is a lung pathology or the pulmonary circulation pathology. And there can be, if there is a lot of third spacing or the capillary leakage, the indicator can recirculate, or there can be leakage or extravasation. All this has an influence on the calculation of the cardiac output. So these are some of the limitations of the transpulmonary thermodilution. So that I think, so these are the limitations which has undermined our usage of cardiac output. So obviously, as you know, in transpulmonary thermodilution, it is basically, we look at the passage of the injectate. So it is very simple. The science is simple. The injectate passes from the right atrium. It will capture the right atrial end diastolic volume. It enters the RV. It calculates the right ventricular end diastolic volume. It will enter the pulmonary artery. It will calculate the pulmonary blood volume. Goes into the LA, left atrial end diastolic volume. So it's very simple. As the indicator passes, the volumes are captured, and based on this, the other variables are derived. And basically, we look at two important things. There is a downslope time, and there is a MTT, is the mean transit time, and downslope time. So basically, this is the movement of the indicator, which are plotted as a graph, and cardiac output is calculated. And there are certain derived variables like intrathoracic thermal volume you can calculate, which is cardiac output into mean transit time. Pulmonary thermal volume is calculated as cardiac output into downslope time. And global end diastolic volume, which is an indicator of the preload, is calculated by intrathoracic thermal volume minus pulmonary thermal volume, or it can be calculated as cardiac output into mean transit time minus downslope time. And intrathoracic blood volume can be calculated as 1.25 into cardiac. So these are all derived variables based on mean transit time and downslope time of the passage of the indicator through all the different dimensions of the heart. And what is important, the advantage that is cited for PICO is that it can calculate extravascular lung water, which the PA catheter cannot do. And this is calculated by subtracting intrathoracic thermal volume minus intrathoracic blood volume, or intrathoracic thermal volume minus 1.25 into global end-diastolic volume. But in PICO, if you are arguing that it gives extravascular lung water, we have B lines, or we have ultrasonological identification of extravascular lung water, and there are studies which I will show you. But there are limitations of extravascular lung water if the patient has PE, and or if patient has ARDS, because there is shift of the pulmonary circulation. You know, there is a pendulum effect where there is shift of pulmonary circulation from the basal regions to the apical regions, and both of these can underestimate extravascular lung water. And when you apply PEEP, there is pulmonary vasoconstriction and the reduction in the hydrostatic pressure. All of these can underestimate sort of extravascular lung water, because there may be more, but because of the presence of ARDS and because of pulmonary vasoconstriction, or if there is PE, it underestimates. Or if patient has a massive pleural effusion, and in ICU, many of them would have bilateral pleural effusion for various reasons, or someone who's had a lung resection. So this PICO or transpulmonary thermodilution overestimates extravascular lung water. So these are some of the caveats. So we spoke about the limitations of the pulmonary artery, and we are speaking now of the limitation, because the PICO is usually touted as a benefit because we get extravascular lung water, which can be debunked because of these limitations. Then we'll talk about pulse contour analysis, where you usually take the area under the curve of the stroke volume of the pulse pressure. So aortic pulse pressure is taken as a correlation to stroke volume. And basically, this is calculated as resistance and compliance. You measure the resistance and compliance, and cardiac output. Basically, you take the pulse pressure at the aorta, and that is taken as a correlative of stroke volume. Cardiac output is calculated as mean arterial pressure at the aortic level divided by resistance and compliance. So this is how pulse contour analysis is taken, and there is a Windcastle sort of an equation that is used to derive the cardiac output. So the empiric approach is stroke volume is calculated by taking the standard deviation of the arterial pressure as being proportional to the pulse pressure. So this is the sort of the understanding that we have in derived. So there are a lot of derivatives that we take or assumptions that we make to calculate cardiac output by using certain equations, and this is how it is attained. And what are the factors affecting the accuracy of pulse contour? It is because aortic compliance is non-linear, and aortic sort of a compliance reduces with age, and it increases with sort of reduced compliance happens with increasing age. And this also has a bearing on the cardiac output measurement. And the waveforms, as we know, like any other arterial waveform, there could be sort of a fallacies in the waveforms. It could be dampened waveforms, and this can give a sort of an underestimation of the cardiac output, or there can be inadequate detection of pulse rate. And if there is any aortic pathology, the waveform that is captured under the curve and as a correlation of the stroke volume becomes erroneous. So there are aortic pathologies basically erroneously depict the cardiac output, and these are some of the limitations of this. So now we'll talk about summary. So I've spoken about PA catheter, I've spoken about transpulmonary thermodilution, I've spoken about pulse contour analysis, which are the three common sort of tools that we use in ICU to measure cardiac output. And summarily, what are the advantages and limitations? When we talk about transpulmonary, it is as reliable as pulmonary thermodilution as a main advantage, but the drawback is there is no continuous measurement. Why we say there is no continuous? Because every time you need to measure cardiac output, you need to inject, cold injected, and that obviously that is captured, and then the waveform is built, and then you calculate the cardiac output. So when you talk about pulse contour analysis, because it's like an arterial waveform, you capture the area under this waveform, and it is a continuous measurement. It gives a precise estimate of cardiac output and assesses the small changes in the cardiac output and assesses short-term and small changes in the cardiac output. But this needs regular calibration, because the dampening of the waveform or zeroing may be a problem, dampening can happen, and so on and so forth. So regular calibration is what is needed. So when we talk about global end-diastolic volume, which is derived, it is a derived variable from transpulmonary thermodilution. It is a good reflection of preload, but as I said, it does not tell you whether differentiate between the cardiac output of the right RV or left piece. It is unable to delineate the cardiac output where it may be suboptimal, and it is not a good reflection of pulmonary edema. And when we talk about stroke volume variation, the main advantages is continuous, automated. It's a good automated response of fluid responsiveness, but it is unreliable because stroke volume variation is something we do in our ICU from the monitors, but we know it is unreliable when patient is spontaneously breathing, patient has arrhythmias, or patient has severe ARDS. We do this in our ICU, SVV, we do act upon it, but it gives a good measure of whether patient is fluid responsive or not. But when patient is spontaneously breathing, or when someone has valvular disease, arrhythmias, or severe ARDS, we know this stroke volume variation becomes unreliable. And extravascular lung water, the main advantage is it is reflective of the pulmonary edema, but we saw the fallacies or limitations. It underestimates sort of extravascular lung water when there is pulmonary thromboembolism or when there is severe ARDS, and it overestimates when there is lung resection or massive pleural effusion. So this is just a summary slide to show all the advantages and the disadvantages of pulmonary thermodilution. So now we'll talk about why echocardiography. So echocardiography is an important tool. Now it is a standard of care. Any patient with circulatory shock, it is mandatory that we need to look at the heart to see whether heart is functioning normally, because all your fluid responsiveness concept comes from whether your LV or the cardiac output is adequate to or is commensurating to the fluid bolus that you have given. So that is the whole concept of dynamic fluid responsiveness that we see, and it is mandatory. And transpulmonary thermodilution, we know it is invasive and it is cost prohibitive because it incurs cost. And transpulmonary thermodilution is nurse driven because all the cold injected that you give, build the waveform, all these are done by the nurses. It is not doctor driven. And so when you talk essentially summarily of the monitoring, we can't take one variable. We have to importantly take the clinical variables and try to take the variables which are less invasive or which is least invasive. Minimally invasive hemodynamic tool is what we need to adopt. That's why echo seems to be more pragmatic and prudent sort of a tool, because it gives an accurate bedside assessment of LV systolic function. And by doing Doppler, by doing M mode, we can make various functional assessment. Like you can look at diastolic function, you can look at tissue Doppler, you can look at the filling pressure, and you can look at the valvular sort of a pathologies. And most importantly, you can visualize how the heart is beating. You can visualize all the structural components of the heart, which you cannot do it in transpulmonary thermodilution. So these are some of the salient benefits of echocardiogram. And when you talk about extravascular lung water, because the same extravascular lung water, which is cited as an advantage for with TPTD, transpulmonary thermodilution, can be looked in lung ultrasound by looking at the B lines. So B lines are hypoechoic lines, and as you see, it erases the A line, and 7 millimeter separation between the hyperechoic suggests interstitial edema. And if it is less than 3 millimeter between the hyperechoic, you can say it is alveolar edema, and it extends all to the bottom. And these B lines occur due to the entrapment of fluid in the interlobar septa, and the thickness of this interlobar septa due to the fluid accumulation determines the B lines. And why that happens? Because the ultrasound waves get trapped in this interlobar septa and reverberates, and that is the reason why you get these B lines. This is from the physiological aspect why these B lines occur. And this is just some of the images in our own ICU where we have done B lines. As you see, this is the interstitial edema where they're separated by 7 millimeter. And this is the alveolar edema where you have a very dense sort of a B lines, which is less than 3 millimeters. So very simple tool. You don't need a transpulmonary thermodilution to determine that there is extravascular lung water. So now we'll talk about, can we measure cardiac output by echo? Yes, you can measure cardiac output by echo. It's a very simple. So you just have to go on a parasternal long axis view and take the cross-sectional area of the LVOT. And generally for males, the LVOT is 2 centimeter. For females, it's 1.7. And stroke volume is simply LVOT cross-sectional area into LVOT VTI. And cardiac output is stroke volume. It's very simple. So you can do it in echo intermittently and calculate the cardiac output. And the Doppler measurement of cardiac output, you put the sample, you take a 5-chamber view. As you see, this is the LV, this is the LA, and this is the LVOT. You keep the sample just above the LVOT, and you will get put a Doppler, you will get a LVOT VTI. So you just take this trace that will give you LVOT VTI, and you calculate, if you multiply by LVOT cross-sectional area that gives you stroke volume into heart rate is cardiac output. So cross-sectional area need to be calculated with this formula 3.14 into diameter divided by 2 squared. This gives you the cross-sectional area with regards to the centimeter squared, and this has to be multiplied by VTI. So now, so we spoke about the advantages. So echo is minimally invasive. You can do a lot of measurements. You can structurally visualize the heart. And with the echo machine, you do a lung ultrasound, capture B line. So you pretty much have all the information that you are getting from transpulmonary thermodilation. Now you have to see, is there a good evidence to say that transpulmonary thermodilation is as good as echocardiogram? So we have a good evidence. So this is a meta-analysis where, as you see, it came in 2019 by Chinese group, where they compared cardiac output measurement versus echo, a systematic review and meta-analysis. They have taken 68 studies, 1,996 patients, calculated cardiac output by echo and thermodilution, and they found no difference between the echo and the thermodilution. And as you see, that did not attain statistical significance. There was no difference. So you can use echocardiogram. And now you can talk about whether echo is as good as extravascular lung water. So for that, there was this Italian study which came in 2017, simplified lung ultrasound to detect increased extravascular lung water. They took only 19 patients and they looked at if patient had B lines in more than 3 positive lung quadrants, and they compared it with extravascular lung water of more than 10 ml per kg. So they had a good correlation. So if you have B lines more than 3 quadrants, so that was corroborative of having someone having extravascular lung water of more than 10 ml. And they had a good correlation where, as you see, ROC was 0.89, and that was statistically significant. And if they increased it to 4 positive lung quadrants, ROC remains. So if you have more than or equal to 3 lung quadrants, it is as good as saying they have increased extravascular lung water, and you have to diuresis this. So we have good evidence to suggest cardiac output with echo is as good as TPTD, and extravascular lung water, your lung ultrasound is good enough, and you don't need transpulmonary thermodilution. So summing up, so these are all the tools that we have today to calculate cardiac output. And this is the summary advantages and limitations of transpulmonary thermodilution. So as many advantages are there, that many limitations and disadvantages are there. So the answer for the question that was given to me is TPTD obsolete in the phase of POCUS? Possibly yes, because ultrasound and echo is something that we use every day, easily available, non-invasive, less cost, and learning curve also is not too much with so much of training that is happening. And you get possibly more information and more sort of a fulfilling to do ultrasound because you're visualizing the structures. So thank you one and all. So I request you all to submit your valuable work to Journal of Acute Care, which comes out every quarterly. So you can visit my website, www.drpradeepranduka.com, to read to this. So thank you one and all.